Hi, this is Adam Singer, and the title of my paper is Development of a Porcine Model for Eschars, an Evaluation of a Novel Bromelain-Based Enzymatic Debriding Agent. The study was funded by MediWound, and Yaron Shoham, who is one of the authors, is a paid consultant for MediWound. So each year there's over 6 million chronic wounds in the US alone. Development of novel therapies has been limited by the lack of animal models. Doxorubicin, which is an anti-neoplastic agent, is known to cause skin necrosis after accidental extravasation. And so therefore, we chose to use this agent to create a chronic wound model in pigs, who are the optimal animal model for wounds. We developed a novel porcine eschar model and evaluated the efficacy of a novel enzymatic debriding agent using this model. We hypothesized that intradermal injection of doxorubicin in pigs would result in necrotic skin ulcers, which are similar to human chronic ulcers. We also hypothesized that a novel bromelain-based enzymatic debridement agent would result in more rapid and effective wound debridement than the only commercially available enzymatic agent, collagenase, using this same model. First, we created full-thickness excisional wounds on 3 pigs. We then injected the edges of the wounds with various concentrations and volumes of doxorubicin, and then monitor the wound for a period of 46 days to see the development of eschars. In A, you see a full-thickness excisional wound 10 days after infliction, during which time we covered it with an occlusive dressing. You can see erythema in the healthy skin surrounding the wound. In B, the same wound is seen 18 days after infliction, after which time we covered it with gauze. What you see is 2 distinct areas. In the center, you see a yellow slough, which is like chronic ulcers in humans, and in the surrounding periphery, you see necrotic tissue. So here we see representative 3 by 3 centimeter chronic wounds that were injected with various concentrations and volumes of doxorubicin. The conditions that we chose that were optimal are seen in F, where you see again the surrounding necrotic tissue, the black tissue, and then in the center, this slough or exudate of proteinaceous material and debris. Under the microscope, this is what it looks like. The periphery, you see this mummified necrotic tissue, condensed, and then granulation tissue below that, whereas in the center, you see this paucicellular exudate, below which we see the granulation tissue. So after finding the optimal conditions to create these chronic ulcers, we created additional chronic wound ulcers in another set of animals and then treated the eschars with up to 16 daily applications of various concentrations of the novel enzymatic agent called Eschars or collagenase. The Eschars is a concentrate of proteolytic enzymes enriched in bromelain, which is derived from pineapple stems. What we see here is the median number of applications required to achieve complete debridement of the chronic ulcer. In the center, you can see with all the various concentrations of the novel agent, it was about 4 to 5 applications, whereas with the collagenase, we applied 16 applications, and in some of the wounds, debridement was not achieved even after 16 applications, as you can see here. In this image, we see representative wounds before and after application of the various concentrations of the Eschars and at the bottom collagenase. What we see here, for example, in J and I, you see the necrotic slough in the center and the necrotic tissue surrounding that after 10 applications of the Eschars, and in fact, after a median of 4 to 5, not only was the center completely clean of necrotic tissue, but you no longer saw any necrosis in the surrounding area. On the other hand, with collagenase, even after applying 16 applications in many of the wounds, there was still some necrotic ulcer or slough in the center, as well as the necrotic tissue in the periphery. Now, this study does have limitations. It was a relatively small sample size. Of course, pigs, they are good models, but they're not exactly humans, and we can't extrapolate or generalize directly to humans. Furthermore, follow-up was relatively short compared to what happens in humans, where healing can go on for many weeks and months. In conclusion, we describe a porcine model for creating Eschars, which is similar to chronic wounds in humans. We also show that a novel bromelain-based enzymatic debridement agent was significantly more effective than a commercially available collagenase in removing Eschars in this wound model. And finally, we believe that this data support ongoing clinical trials of the EscharX. Thank you very much.
Hello, everyone. My name is Abhishek Naidu. I'm a fourth-year medical student at Stony Brook University and will be starting residency in ophthalmology this July. Before I begin, I would just like to thank you for joining this virtual presentation and would also like to thank the Society for Academic Emergency Medicine for organizing this conference amidst these challenging times. The topic of my presentation today is really just an exploration of the characteristics and trends of emergency department visits in the US, specifically for ocular diseases and injuries over a 12-year period between 2006 and 2017. As you probably know, ocular diseases and injuries are significant contributors to healthcare and socioeconomic costs worldwide. And in the US, EDs play a critical role in the delivery of eye care. Although most ocular diseases and injuries are managed by eye care professionals in an outpatient setting, ED physicians and staff are faced with a multitude of ocular conditions requiring medical or surgical intervention. However, a large proportion of eye-related ED visits do not necessarily require ED-level care and may actually even pull resources away from true emergencies. In the study, we wanted to take a closer look at the epidemiology of these eye-related visits to see how things have changed over the 12-year period and how we can use this data to further guide and improve the management of eye-related visits to the ED. Our data source was the National Hospital Ambulatory Medical Care Survey, or the NHA-MCS, which provides abundant information regarding the provision of hospital ambulatory care in the US. An important limitation to note about this dataset is that it uses a sampling methodology to extrapolate the data and make national estimates. Using SPSS, we identified and categorized all eye-related ED visits using ICD-9 and ICD-10 codes as shown here. We then analyzed a large number of descriptive variables and used linear and logistic regression analysis to describe trends over time and identify the effects of independent variables on specific outcomes. Here are some of our results. In our 12-year study period, an estimated 23.2 million, or about 1.5% of ED visits, were for ocular disease or injury as the primary diagnosis. The mean age of presentation was about 31 years old, and males had a significantly higher proportion of eye-related ED visits compared to females. Interestingly, eye-related ED visits during the warmer months of April to September were significantly higher than the colder months between October and March. With regards to insurance, private insurance was the primary method of payment for about 45% of eye-related ED visits in 2006, but this declined to 23% in 2017. In contrast, the utilization of Medicaid for eye-related ED visits grew from about 20% to about 42% over the same period. And in 2017, Medicaid comprised the largest source of payment for eye-related ED visits. Taking a look at the actual ocular conditions that present to the ED, we found that about 60% of visits were for ocular diseases unrelated to injury. Among these, the most common primary diagnosis was, unsurprisingly, conjunctivitis at over 53%. Ocular injuries comprised about 35% of these visits, with the most common injury being superficial corneal or conjunctival injuries, such as corneal abrasions, at about 46%. Taken altogether, conjunctivitis was still the most commonly seen eye complaint in the ED at around 32% of all eye-related visits. When analyzing the acuity of these eye-related visits, we found that about 5.6% of visits were deemed to be emergent based on a triage ranking provided by the survey. We also found that the incident rate of emergent eye-related ED visits had declined significantly from 2006 to 2017. Lastly, Although the total number of ED visits for all causes increased significantly over the 12-year period, there was no significant change in the estimated number of ED visits for eye-related issues. Additionally, the population-specific incidence of eye-related ED visits did not change significantly over the same time period. Our study results demonstrate that the ED is oftentimes the primary source of care for non-acute ocular conditions for many patients. Urgent care centers oftentimes just do not have the necessary equipment or skills to rule out serious diagnoses. This data essentially confirms that EDs across the US have and will continue to see eye-related complaints. Therefore, it is crucial that ED physicians and residents be appropriately trained on the basic eye exam and be confident in their use of a slit lamp so they may accurately identify ocular pathologies that may require a referral to a specialist or treat the patient appropriately in the ED itself. In the future, it will be important for alternative healthcare settings, such as urgent care centers, to possess the necessary equipment and expertise to be able to identify and treat non-acute ocular conditions. This will undoubtedly lessen the burden of care on EDs, allowing for more time and resources to be allocated in a more efficient manner. Thank you for listening and enjoy the rest of the conference.
Welcome to my presentation on adverse events after pre-hospital nitroglycerin administration, an analysis of a nationwide registry. I'm Lucas Pope, a second-year medical student with Wake Forest School of Medicine. Here are our disclosures. Nitroglycerin is a core medication in the treatment of pre-hospital chest pain patients. Several adverse events have been noted following nitroglycerin administration, with a rate of 1.3% in the pre-hospital setting. Given the uncertainty in identifying patients who may experience potentially serious adverse events, some have questioned the administration of nitroglycerin in the pre-hospital setting. Pre-hospital care providers have expressed concern over these potential adverse events and have in some cases chosen to forego nitroglycerin administration, but this deprives the patient of a potentially therapeutic intervention. The primary objective of this study was to investigate the patient-level characteristics of those that receive nitroglycerin in the pre-hospital setting in an attempt to identify risk factors for nitroglycerin-associated hypotension, bradycardia, tachycardia, and altered mental status. By identifying these risk factors, pre-hospital care providers may be able to more comfortably administer nitroglycerin to treat ischemic chest pain and improve patient comfort. A national retrospective cross-sectional study of chest pain patients across the United States was performed over a one-year period by querying records from 1,322 EMS agencies that agreed to share their de-identified data in the ESO Data Collaborative. The ESO EHR software facilitates the collection of comprehensive clinical information, including patient demographic characteristics, clinical presentation and course, and intervention and treatment. All adult 911 encounters with a chief complaint of chest pain that were given oral or sublingual nitroglycerin by EMS personnel were included in the analysis. Adverse events were defined as a systolic blood pressure less than 90, a mean arterial pressure less than 65, a heart rate less than 50 or greater than 120, or a change in mental status from alert. These events were required to have occurred within 10 minutes of nitroglycerin administration by an EMS provider. Multivariable logistic regression modeled the effects of age, sex, race, ethnicity, initial vital signs, and IV access on adverse event occurrence. Results are reported as adjusted odds ratios and are reported with exact 95% confidence intervals. An a priori alpha level of 0.05 was determined. There were 124,933 encounters included in analysis. The median age was 61 years. Males accounted for 52% of the sample, white patients accounted for 69%, and Hispanic patients accounted for 7%. IV access was obtained in 80% of the encounters. Adverse events occurred in 3% of encounters. Logistic regression demonstrated that adverse events following nitroglycerin administration were less common among male, African American, and Hispanic ethnicity populations. Adverse events and encounters with IV access obtained prior to nitroglycerin administration were less common. Age and heart rate were directly associated with adverse events, while systolic blood pressure was inversely associated. Subgroup analysis of the adverse event population demonstrated that an initial systolic blood pressure less than 120 resulted in 34% of adverse events due to hypotension, with those less than 130 resulting in 54%. Adverse event likelihood due to hypotension was shown to increase as initial systolic blood pressure decreased, with dramatic increases found within the 100 to 120 domain. This nationwide retrospective pre-hospital study demonstrated that adverse events associated with receiving nitroglycerin were rare, occurring in just 3% of encounters. Despite the known adverse effects of nitroglycerin, the infrequency of these adverse events should provide reassurance to pre-hospital providers and EMS medical directors that nitroglycerin is safe in the pre-hospital environment. Due to the increased rates of adverse events, EMS providers should be wary of administering nitroglycerin to patients with a systolic blood pressure of less than 110 or heart rate greater than 100. This study demonstrated that adverse events were less common in male, African American, and Hispanic patients. Several studies have reported an increased rate of cardiovascular events in these populations. Withholding nitroglycerin from these populations due to this preconceived risk would inappropriately report lower rates of adverse events, suggesting that the preconceived cardiovascular risk in these populations were incorrect, and nitroglycerin should be administered when appropriate, regardless of demographic data. The data in this convenience sample were heavily focused in the southern U.S. and may not be generalizable to all patients with chest pain. Manual data input by pre-hospital providers could have led to unintended data collection errors. Characteristic of pre-hospital research, the EMS dataset is limited and unable to be linked with outcomes data. An adverse event occurrence required definition by pre-hospital presentation only. Medication interactions were not addressed in this study. Due to the inevitability of sicker patients requiring additional medications, the study was not designed to accurately address these interactions. The number of nitroglycerin doses administered in each encounter also was not addressed in this study. If an adverse event were to occur, additional nitroglycerin doses would not have been administered, falsely suggesting that increased administrations led to lower rates of adverse events. This national pre-hospital study demonstrated that adverse events following nitroglycerin administration were rare. Demographics were not found to be clinically significant and should not deter EMS personnel from administering nitroglycerin. IV access should be established prior to nitroglycerin administration when available. Feel free to pause for a list of references. Thanks for listening, and please forward any questions to me, Lucas Pope, with the Wake Forest School of Medicine. Have a great day.
Hello, my name is Gurvijay Singh Bains, and I am a current EMS and Disaster Medicine Fellow at the University of California, San Francisco. This presentation is on the pilot project CADDY, which stands for Centralized Ambulance Destination Determination. In this presentation, we look at the impact of CADDY on level loading of the system, surge events, and diversion. The objective of this pilot project was designed to improve the distribution of EMS patients and transports throughout local hospitals in order to improve timely patient care. This is accomplished with physicians and paramedics utilizing real-time and daily system data, providing online direction to EMS crews in the field prior to making a transport decision. In assessing the program, preliminary outcomes studied in this project focus on transport to emergency department bed ratios, EMS surge events, and the impact on diversion. For diversion, many hospitals in San Francisco go on what is called diversion when they are unable to keep up with the demand of a busy emergency department. Now, ambulance diversion has been shown to contribute to longer pre-hospital treatment and transport times, financial loss to hospitals, and increased emergency department overcrowding, and actually may be amenable to system-driven improvements, which actually include decreasing elective surgeries, decreasing boarding in the ED, and establishing fast tracks for lower acuity patients. One potential solution to decreasing diversion was to see if offloading an emergency department with EMS would help prevent diversion rates, which is one of the points of this project. For this project, there were 4 portions. First was the baseline period during the COVID-19 pandemic, where CADDY was not being utilized. Then, phase 1 from April 16th to July 3rd of 2020, CADDY was operational 24 hours a day, but only as a recommendation, so EMS did not always have to call for destination determination. Phase 2, from July 3rd to October 26th, CADDY was operational 24 hours per day, and hospital direction to EMS crews was mandatory for all transports. Based on compliance rates and feedback from hospitals and EMS, a modified approach to CADI was done in an attempt to improve the outcome of the program. Therefore, during Phase 3 from October 27th to February 2nd, 2021, CADI was operational between 7 a.m. and midnight, 7 days per week, and hospital direction to EMS crews was a recommendation. A primary goal of CADI was to level load the system, reducing the relative transport volume for heavily impacted hospitals and increasing volume at less impacted hospitals. A target average ratio of 1 was used. The coefficient of variation, which is the standard deviation in relation to the mean, amongst hospital ratios is used as a measure of relative variability, with lower variation suggesting improved ambulance diversion. We have significant evidence to show that there was a reduction in the mean CV between baseline and Phase 2 and baseline and Phase 3. This actually showed that the optimal and smallest variation occurred during the recommendation in Phase 2 when CADI was mandated. Also, CADI helped decrease surge events for 3 highly impacted hospitals in San Francisco. The definition used for a surge event was when an ambulance arrival to an ED surpassed 30% of their licensed ED bed count, or was equivalent to greater than 6 transports to an ED per hour, whichever was the lowest. The results of this showed that compared to baseline versus Phase 1, 2, and 3, there was a statistical significance that the CADI project had a positive impact on the surge events at 3 heavily impacted hospitals, including the most heavily impacted hospital and the only level 1 trauma center in the county. Diversion paradoxically went up across a hospital system, which may be due to increased boarding in the ED due to unavailable ICU beds, decreased staff due to callouts, or even decreased staffing due to budget cuts and higher acuity during the COVID-19 pandemic. Interestingly, transport volumes have remained the same over the last 1 year since COVID lowered the volumes in general. However, diversion fluctuates and overall goes up, which may mean that EMS transport volume may have no bearing on diversion rates. In conclusion, this CADI project has proven to improve distribution of patient transports. It also has shown that surge events have decreased, leading to overall less diversion times for 3 of the very highly impacted hospitals in San Francisco. However, diversion rates overall have increased despite lower overall volumes. Interpretation of this preliminary data is challenged by many unaccounted factors, most notably the effect of a COVID surge on the EMS system. Thank you for your time.
My name is Josh Lupton. I'm from Oregon Health and Science University, and I'm going to talk to you about the accuracy of pre-hospital initial rhythm interpretation during out-of-hospital cardiac arrest. Here are my excellent co-authors on this study. I'm a recipient of the Zoll Foundation Research Grant for a separate project that is in no relation to this project or this presentation. Rapid rhythm analysis in out-of-hospital cardiac arrest has been shown to reduce compression pauses and is the main advantage of human over AED interpretation of rhythms during a resuscitation. There's additionally been a continued push to reduce pauses in chest compressions during cardiac arrest care, as improved chest compression fraction has been associated with better patient outcomes. However, the accuracy of human rhythm interpretation compared to post-hoc review has been poorly explored. Our project sought to examine the question, how accurate is pre-hospital initial rhythm interpretation during an out-of-hospital cardiac arrest by ALS-trained EMS providers compared to post-hoc consensus review. Our project included an analysis of 2 years of cardiac arrest cases treated by a single FireFirst ALS first response agency in Oregon. All cases used the same defibrillator manufacturer, and inclusion criteria were an EMS attempted resuscitation, monitor files with rhythms and CPR feedback available, and the defibrillator must have been in manual mode during the initial rhythm interpretation. We then obtained from eligible cases a blinded 6-second rhythm strip that was extracted during the first CPR pause period corresponding to the initial rhythm check time from the EMS chart. 3 physicians who are ACLS instructors were then blinded to the EMS rhythm interpretation and independently reviewed each rhythm, categorizing the rhythms as either shockable, such as VT or VF, or non-shockable, such as PEA or asystole. To extract the blinded rhythm for review, we would take the entire case monitor file, locate the time corresponding to the initial rhythm analysis, and extract a 6-second window where no CPR was performed to provide a blinded rhythm for review. Post hoc rhythms where there was unanimous agreement between the 3 reviewers were used as our gold standard, and then we compared EMS rhythm interpretation to this gold standard, calculating sensitivity, specificity, positive and negative predictive value. Now getting into our results. There were over 300 cardiac arrests, of which just over 200 had EMS resuscitation, 89 had all of the variables needed for our review, and of those 89, 78 had unanimous consensus on the rhythm from our 3 reviewers. This slide shows that the 78 cases, of which there was unanimous consensus from our reviewers, had a similar distribution of rhythms to the study sample and the overall EMS-treated cardiac arrests in this time period. Among the 78 rhythms with unanimous agreement from our post hoc reviewers, the initial rhythm was determined to be shockable in 29 instances and non-shockable in the remaining instances by our post hoc review team. EMS interpreted 23 of the 29 shockable rhythms as shockable and 6 as non-shockable, and they interpreted 2 non-shockable rhythms as shockable, these areas highlighting 6 instances of missed shocks and 2 instances of inappropriate shocks. This slide shows an example where our reviewers and EMS all agreed on asystole. This is an example where they all agreed on PEA. And here's an example of 3 cases where they all agreed on a shockable rhythm. This slide shows 3 cases where our post hoc reviewers felt the rhythm was shockable, but EMS's interpretation of this rhythm was that it was consistent with asystole. Here you see 2 cases where our post hoc reviewers felt the rhythm was PEA, but the rhythm was interpreted as shockable from EMS. Here we have the overall accuracy of our EMS initial rhythm interpretation for shockable rhythms compared to our post hoc review, of which we reveal a sensitivity of 79% for EMS to detect an initial shockable rhythm, a specificity of around 96%. This corresponds ultimately to a positive predictive value of 92% and a negative predictive value of 89% for EMS to determine a shockable initial rhythm. However, despite these high values, approximately 1 in 5 shockable rhythms in our sample were misclassified initially by EMS. Our study has several limitations. Most notably, this was a single agency retrospective review of all available monitor files over a 2-year period. Additionally, our gold standard used was a unanimous rhythm consensus among our 3 reviewers, as opposed to a simple 2 out of 3 majority, though this likely would underrepresent misclassification, as we are only choosing rhythms for which all of our reviewers had unanimous agreement on, and thus perhaps they are more likely to be obvious initial rhythms. In this slide, you'll see results from our study in green, showing human rhythm interpretation accuracy to detect a shockable rhythm with 95% confidence intervals. You will then see prior published studies, of which they've all focused on AED accuracy to detect a shockable rhythm compared to post hoc rhythm review. You will note that across the board, our accuracy appears to be slightly lower in our study compared to these past AEDs, though due to the low sample size, the 95% confidence intervals frequently overlap these prior results. Future larger, more generalizable studies are needed to confirm if human rhythm interpretation is, as we report, mildly less accurate than AED rhythm interpretation. If this is confirmed, future studies could see how integrating an AED when the rhythm is uncertain could improve sensitivity to detect shockable rhythms, or they could look at novel technology using analysis during chest compressions and integrating that with manual rhythm interpretation from ALS to see if it improves sensitivity. Thank you for listening. I welcome.
Hi everyone, my name is Peter Al-Sharif. I'm an emergency medicine intern at Rutgers, New Jersey Medical School, and today I'll be telling you about our project, the administration of Naloxone during COVID-19 by an urban, hospital-based emergency medical service. We have no financial conflicts of interest to disclose. Now, for some background, overdose deaths accelerated nationally during the early COVID epidemic, and Essex County, New Jersey is particularly affected by the opioid epidemic, with almost double the rate of deaths per capita compared to the United States on average. Now, naloxone is used for the reversal of opioid-induced respiratory depression, and it is generally safe and effective. However, there is a risk of precipitated withdrawal syndrome. It can be given intranasally, intravenously, or interosseously, and the use of airway and ventilatory support is encouraged. In this project, our objective was to ascertain if the rate of adverse events after naloxone is given is associated with the route of administration. We also wanted to assess if patient responses to naloxone were associated with the route of naloxone administration. And finally, we wanted to determine the likelihood of providers giving ventilatory support and/or transport to the emergency department throughout the COVID-19 crisis, and to see if there was any effect of the type of provider, either ALS or BLS. So this is a retrospective chart review study where we looked at all EMS reports from January 1st to November 15th of 2020 that had naloxone listed in the medication administration record. We excluded all the cardiac arrests and duplicate reports. We manually reviewed each of the charts. The investigator was assigned to a chart using a random number generator. Our independent variables were the route of administration and the provider type. Our outcome measures involved the rate of adverse events after naloxone. This was our primary outcome. We also looked at the rate of improvement in respiratory status. We used a logistic regression to control for initial respiratory rate, initial mental status, and presence of pinpoint pupils. We looked at how often respiratory support was provided to these patients, and we looked at how likely the patient was to be transported to the emergency department. So during the time period that we looked at, there were 778 patients who received naloxone. There were 54% that got naloxone from an ALS provider and 46% that got naloxone from a BLS provider. And about 86% of these patients received intranasal naloxone and 14% received IV or IO naloxone. So this figure shows the rate of naloxone administration per day throughout the time period. And we see that the number of naloxone administrations in April reached a nadir, which corresponded roughly with the peak of the first COVID-19 surge. So for our primary outcome, we found that the route of naloxone administration had a statistically significant effect on the likelihood of an adverse event occurring, with about 8% of patients receiving intranasal naloxone having an adverse event compared to 15% of those that received IV or IO naloxone. And this was mainly driven by a difference in the rate of vomiting after naloxone was given, with IV or IO naloxone recipients being more likely to vomit after naloxone. We also saw that there was no statistically significant effect of route of administration on improvement in respirations, with between 75 and 80% of naloxone recipients experiencing improvement. And using our multinomial logistic regression to adjust for baseline respiratory rate, mental status, and presence of pinpoint pupils, it confirmed that there was no statistically significant effect of route of administration on improved respirations, and that intranasal naloxone was less likely to be associated with an adverse event than IV or IO naloxone. There was no effect on the route of naloxone administration on the likelihood of ventilatory support being provided to these patients. We did, however, see that BLS providers were more likely to provide respiratory support to these patients throughout 2020. Interestingly, we found that around 90% of these patients were transported to the emergency department, and there was no statistically significant effect of route of naloxone or type of provider. So we found that parenteral naloxone was associated with a higher rate of adverse events compared to intranasal naloxone, particularly vomiting. There was no statistically significant difference in the rate of response to naloxone based on the route. We also found that ventilatory support decreased in 2020 compared to previous years. There were about 3/4 of patients in 2018 and 2019 who received ventilatory support, whereas only 1/4 of patients received it in 2020. It did reach a nadir in April and May of 2020, which did correspond with the peak of the COVID-19 surge, and BLS providers were more likely to provide the ventilatory support. There was no trend throughout this time period in transportation to the emergency department, with over 90% of patients being transported. There were some limitations to our study. This is a retrospective review, so there are likely confounders that we hadn't considered. We did not consider the dosage of naloxone that was given. It was largely dependent on the quality of EMS documentation, and there were shifting guidelines and practice patterns throughout the pandemic. Our future directions involve education and training for EMS personnel, encouraging preferential intranasal naloxone and providing safe ventilatory support to these patients using mask straps and viral filters, and evaluating the role of end-tidal CO2. So I'd like to thank Dr. Sule, Dr. Kenyon, Gail, and Eleanor for helping us make this project possible. And here are a few references. And I would love to answer any of your questions. Thank you for your attention.
Thank you for joining me at SAEM 2021 and in this lightning abstract session. My name is Meredith Masters, and I am a clinical assistant professor, as well as the Mark and Laura Andreasen Medical Director for Disaster Relief in the Stanford Department of Emergency Medicine. On behalf of my collaborators, I will be presenting our abstract, Emergency Medical Services Utilization for Stroke, a study of national trends and differences by subgroup. EMS utilization has been linked to higher quality stroke treatment. Often, EMS research is limited by service or system and provides snapshots of certain regions or cities. Using multiple data sources, we constructed a national database of stroke patients, evaluated EMS use over time by different subgroups, and calculated the independent effects of EMS utilization on the use of IV alteplase, or TPA. In this 8-year retrospective cohort study, we examined EMS use patterns of patients over age 66 who experienced their first hospitalization for ischemic stroke. We limited our cohort to those continuously enrolled in Medicare Parts A and B in the year prior to hospitalization. We identified EMS transport using healthcare common procedure coding systems codes in the Medicare carrier and outpatient claims, as listed here. We then calculated Cochrane-Armitage trend tests to examine changes in EMS utilization over time, as well as chi-square tests to assess utilization by patient demographics and geographic location. We used multivariable logistic regression to investigate the connection between EMS utilization and alteplase administration. In doing this, we adjusted for patient demographics, such as age, gender, race and ethnicity, as well as comorbid conditions, and hospital characteristics, such as size and stroke center certification at the time of hospitalization. In our cohort of 252,736 stroke patients, we observed certain trends. Older patients had higher utilization rates than younger patients, with those between 66 and 75 years of age utilizing EMS at a rate of just over 50%. Those aged 76 to 85 at 60%, and those patients older than 86 had an EMS utilization rate of over 70%. Female patients had a higher EMS utilization rate than male patients, with women at 62.6% and men at 56.8%. We observed a higher EMS utilization rate in non-Hispanic white and Native American patients at 61% and 61.9% respectively, compared to Hispanic patients at 57%, Black patients at 56.2%, Asian patients at 53.1%, and patients of other races at 52.9%. During the 8 years of the study period, overall EMS utilization increased from 58.1% to 62.1%. Patients residing in rural areas had a greater increase in EMS utilization compared to urban populations. Rural populations had an increase in EMS utilization from 57.6% to 63.5%, versus urban populations increasing from 58.2% to 62.1%. And lastly, our multivariable model showed that alteplase administration was higher among patients transported by EMS, with an odds ratio of 2.9. In conclusion, stroke patients who arrived via EMS have almost 3 times higher odds of receiving alteplase. The next steps of our research are to delineate the use of BLS and ALS and the effects this has on treatment and patient outcomes. This will help us better understand needs and better provide emergency resources so that we continue to see improved treatments and patient outcomes in the management of ischemic stroke. Thank you for joining me today. I would like to thank my collaborators, as well as the EMS Division and the Department of Emergency Medicine at Stanford.
Thank you for letting us present. I would like to begin by acknowledging my co-investigators. This work was supported by NHTSA, which funds the NEMSIS program, and HRSA, which supports the CHAMP node of PCARN. There is a need to implement evidence-based practice to improve pre-hospital patient care. The evidence needed to effect change must be obtained using rigorous research methodology. In order to conduct high-quality prospective research, background data from retrospective studies are needed to describe the frequency of disease and exposure occurrence. A national data set of EMS responses and transports could be used to facilitate this type of research. The National Emergency Medical Services Information System, or NEMSIS, is a national repository of EMS patient care reports that collects 165 variables. The goal of the Pediatric Emergency Care Applied Research Network, or PCARN, is to conduct prospective EMS research to improve the care of children. To meet this goal, there is a need to rapidly determine the types and numbers of pediatric patients transported by participating EMS agencies. Combining data across EMS agencies at the local level, while technically possible, is complicated and costly. However, leveraging the NEMSIS data to extract PCARN data could be an efficient and cost-effective method of providing network-level data. The objective of this project was to describe the process of creating a PCARN-specific NEMSIS dataset and to determine if these data are nationally representative when compared to the complete NEMSIS dataset. If these PCARN-specific data are used for research, we need to understand the generalizability of the data compared to the larger NEMSIS dataset. In general, individual EMS agencies submit data to their state EMS office, who then provide data to the NEMSIS through a data use agreement, or DUA. These DUAs prohibit the release of data identifying an EMS agency. So to create the data set for this project, a separate DUA was required that would allow the NEMSIS to identify PCARN EMS agencies and provide only their data. Investigators approached both the participating EMS agency and the associated state EMS office and explained the project. If the EMS agency and their state office agreed to participate, they determined who would sign the project-specific DUA. In total, 19 agencies from 9 states completed a DUA. We conducted a retrospective analysis of variables within the PCARN-specific dataset compared to the national dataset for all pediatric events in 2019. No statistical analyses were utilized due to the large sample size. Instead, a difference of plus or minus 5% was deemed to be clinically meaningful. The PCARN-specific dataset included over 305,000 events, of which 6% were pediatric patients, 18 years old and younger. Of the pediatric events, 98% were initiated through the 911 system, and 55% were transported by the documenting agency. The national dataset included 10,062 EMS agencies, which conducted over 36 million events, of which 6% were pediatric patients. Of the pediatric events, fewer, 79%, were initiated through the 911 system, and more, 62%, were transported by the documenting EMS agency. When we compared the demographics between the PCARN dataset and the national dataset, we found that while there were slight variations in demographics between the two datasets, the two groups were similar in age and sex distribution. However, there were significantly more patients documented in the national dataset as Black or African American, 11% versus 23%, and Hispanic or Latino, 4% versus 14%. While the PCARN dataset had over 48% documented as unknown or not documented. This was more than double the missing rate for the national dataset. This comparison of the most common primary impression shows that injury, mental health, and seizure are common in both datasets. But weakness and pain are listed in the PCARN-specific list, but not the national list, and general examination and acute respiratory syndrome are listed on the national list, but not the PCARN-specific list. Finally, this table compares the number of procedures performed across the two data sets. It demonstrates that very few of the pediatric events involved documented procedures, and the rates of procedures being documented were similar across the two data sets. Specifically, cardiac monitoring was the most common and was only performed on just over 5% of cases in either data set. This was followed by cervical spine immobilization, which occurred in just over 1%, and all of the remaining procedures occurred in less than 1%. We have demonstrated that NEMSIS can be leveraged to create a cost-effective network-specific data set. The PCAR network's EMS data are similar to the national data, though racial and ethnic minorities and some primary impressions may be underrepresented. Additionally, more PCAR events originated through 911, and fewer were transported by the documenting agency. This is likely related to the type of participating agencies, their ALS response level, and the diversity of their communities. Finally, we found that pediatric procedures are rare, and thus networks of agencies are likely needed to conduct pediatric research. Thank you for your attention.
Hi, my name is Sarah Hancock, and I'm a third-year medical student at the University of Rochester. I'm here to present our project, a novel educational intervention to improve EMS communication with the deaf sign language user. First, I'd like to thank Dr. Rotoli, who is my mentor and also the PI of this project. We are proud to say that the study was funded by the SAEM/PDIEM Research Grant 2019. So first, an introduction. The cultural deaf are people who communicate primarily through American Sign Language and share a common history, language, and life experiences, and view their deafness culturally rather than medically. They do not view their deafness as a problem or something that should be fixed, unlike most other medical problems. Many people don't actually know this, but ASL has a unique grammar and syntax and is not simply a visual language of English. And in fact, English is a second language for most deaf ASL users. Like many others who do not use English as a primary language, the deaf are a marginalized population that faces communication barriers that are only exacerbated in the pre-hospital setting. As we know, pre-hospital emergencies rely heavily on communication to obtain critical information from the patient and to communicate back to the patient what's going on and what interventions may take place. In this study, we aim to evaluate EMS practitioner comfort levels when communicating with and caring for deaf ASL users, along with identifying what current pre-hospital strategies and tools are being used when communicating with this population. And lastly, we aim to develop and evaluate the effect of an educational training module and novel communication tool that we will introduce in just a minute. So we conducted a pre-post intervention study of the EMS practitioners. Participants were recruited from local EMS agencies around Monroe County, New York, which is the county in which Rochester resides in. This is important to mention because there is a large deaf population here in Rochester. We developed 3 surveys. The first was a baseline survey given prior to the training. The second was an immediate post-intervention survey given at the end of the online training module. And lastly, a 3-month post-intervention survey. Our intervention consisted of 2 parts. The first part included an experiential educational training, and the second part was distributing the communication booklet that EMS practitioners could practice using for 3 months before taking that last survey. The educational training is a 30-minute multimedia online module that focused on deaf culture and communication strategies to both use and to avoid when communicating with deaf patients. The training module also had a video demonstrating the use of the communication tool featuring an EMS practitioner and deaf ASL user. The module utilized a variety of modalities to keep the learner engaged, such as brief readings, audio and visual clips, and checkpoints with knowledge questions along the way. This video here is an example of one of the video clips included in the training module. The second part of our intervention was the development and dissemination of the communication tool. The tool itself is a 15-page, double-sided laminated flip card booklet that has an attached erasable marker. It was designed to follow the order of the EMS practitioner's workflow. The intention was to create a tool that could be mobile, conveniently placed on an ambulance, did not require any Wi-Fi access, and fit seamlessly into the EMS practitioner's workflow. In order to be culturally sensitive, along with meeting the needs of the EMS practitioners, both of these interventions were developed and revised by current EMS practitioners and local deaf community members. So this is what we found. In the baseline survey prior to the intervention, 74% of respondents had responded to a 911 call for a deaf patient. However, only 24% had received training by EMS organizations specific to interacting with the deaf community. Also of note, 83% reported that important details were lost during communication. In the survey immediately after the training module, 93% had reported that the module improved knowledge of deaf culture and communication strategies to use when caring for deaf patients. Also, 96% felt that the module was directly relevant to clinical practice. In the final survey, after 3 months of using the tool out in the community, 100% of those who responded reported that the module continued to be helpful. 95% found the communication tool to also be helpful. Interestingly, 19% used the tool for other non-English speaking patients. It is very clear that there are limited resources to allow for adequate bidirectional communication between the deaf patient and hearing EMS practitioner in the pre-hospital setting. While the majority of EMS practitioners expressed difficulty communicating and limited care due to communication barriers, less than a quarter had received training specific to communicating with deaf individuals. This underscores the need for educational interventions, such as our training module, to be developed and disseminated. We had really great responses to both the module and communication tool, and our next steps include creating a digital form of the flipbook and disseminating these tools beyond Monroe County. Some limitations to our study included difficulties with attrition rates. Our sample size was unfortunately too small to conduct a comparative analysis of changes in knowledge and comfort level over time before and after the intervention. Another important limitation to mention is that since this study was conducted in Rochester, New York, which has one of the largest deaf populations in the US, our results may actually be underreporting the general EMS practitioner's discomfort in communicating with deaf individuals. In closing, I just want to reiterate, deaf patients belong to a marginalized group who experience barriers to care. In our study, EMS practitioners reported communication barriers, discomfort, and perceived patient frustration when communicating with deaf ASL users. Our training module improved knowledge of deaf culture and strategies to improve communication that had a sustained effect even 3 months after the module. The novel communication tool was felt to be useful when communicating with deaf ASL users and may also be applicable with other non-English speaking patients. Thank you, and at this time, we can field any questions.
Good evening, everyone. I'm Anju Wag, and I'm one of the PEM faculty at the Department of Emergency Medicine at Columbia University Irving Medical Center. I will be presenting our survey study of caregivers presented to our PEDS-ED regarding healthcare utilization for their children during the COVID-19 pandemic. I have no disclosures. We are all familiar with these shocking statistics, but since March 2020, the US has seen over 30 million cases, and there have been more than 540,000 deaths due to the COVID-19. New York City was one of the epicenters of the pandemic. New York City hospitals soon became overwhelmed with critically ill adult patients. At the same time, visits to the pediatric ED and hospitalizations dropped significantly, especially during the mandated stay-at-home or lockdown period, which took place between March 22nd to June 12th, 2020. Speculated reasons for this drop in numbers were decrease in infectious illnesses and physical injuries due to school closures and the halting of outdoor activities, including sports, parental concern about catching the COVID infection, and increased availability of telemedicine services. The objective of our study was to understand and assess the modalities of care used for children during the COVID-19 pandemic, and more specifically during the lockdown period, factors that influenced caregivers' decision-making around seeking medical care for their children, caregivers' perceptions of telemedicine, its availability and usage, and their sources for health information about the COVID-19 pandemic. This study was conducted in an urban pediatric ED in New York City. We surveyed a convenient sample of caregivers defined as legal guardians of children who sought care in our ED from a period of July to December 2020. Caregivers who agreed to participate were able to scan a QR code to access the Qualtrics survey, and all responses were stored on the Qualtrics platform. In addition to demographic characteristics of caregivers, the survey asked about the following questions as listed on this slide. The study was approved by the hospital IRB. Our results are reported as percentages of the total number of responses for each question, which is indicated as N. In our study population, about 75% of caregivers were 40 years of age and under. More than 2/3 of the caregivers had higher than high school education. Close to 100% of children had insurance. The commonest type was government or Medicaid, and more than 95% had a primary care provider. This next slide shows the various modalities of care used before, shown in green, and during the lockdown, shown in blue. In particular, note that in-person visits to the primary care office decreased from 63% before lockdown to 9% during lockdown, whereas telemedicine visits increased from 10% before lockdown to 54% during lockdown. Specific telemedicine questions were introduced for the last 2 months of data collection, and the results showed that though 37% of caregivers had heard about telemedicine services, only 7% had used them before the lockdown. Reasons for not utilizing telemedicine were lack of availability, the caregiver not being comfortable with the virtual platform, and no insurance coverage for telemedicine services. No one chose lack of internet access or having the right device as barriers to using telemedicine. 24% of caregivers reported that their children were ill or injured during the lockdown. Mean age of these children was 7 years, and 91% of these children received medical care. Of the 91%, 27 received in-person medical care as depicted in red, 43% remotely as depicted in blue, and 30% as depicted in purple received both remote and in-person care. Of the 9% of children who did not access medical care during the lockdown for illness or injury, the most common reasons given by caregivers were the symptoms were not perceived to be serious enough, they were following media and government advisories not to get medical care for minor issues, and fear of contracting coronavirus infection by accessing medical care. The main complaints reported for the children during the lockdown in blue and those who presented to our ED after the lockdown in red were predominantly fever and infectious complaints like upper respiratory and gastrointestinal symptoms. The next two diagrams show the significant impact the mandated lockdown period had on non-urgent care for children, with 28% missing well child visits and vaccinations, and 26% missing scheduled tests or procedures or specialist visits. Caregivers were asked about their perceived ease of access to medical care when their children have an illness or injury before and during the lockdown. Even though 56% felt that there was no change, 36% perceived access to care was more difficult during the lockdown. The caregivers used multiple sources to get information about the COVID-19 pandemic, with unofficial and non-medical platforms like social media, TV, news, and radio being the major modality over medical and government sources. Limitations of our study include that our population is not necessarily representative of the general population. Some survey questions had incomplete data or small number of respondents, and the information on past illness episodes may suffer from recall bias. In conclusion, even though our caregivers reported a perceived difficulty in accessing medical care, 91% was still able to access care during the lockdown. From our survey data, non-urgent care was markedly affected, and there was a rapid growth in the use of virtual platforms. Further research is needed on telemedicine services to identify barriers for caregivers. And in addition, there needs to be a focus on maintaining continuity of non-urgent care during public health emergencies. We acknowledge and thank the providers and the staff of the Pediatric ED for their effort and support with data collection, and the families who participated in this study. Thank you.
Hello, my name is Matt Neff. I'm an emergency medicine and EMS physician based out of Portland, Oregon. And today I'm going to be taking a few minutes to present my abstract entitled Impact of the Number of On-Scene Pre-Hospital Providers on Chest Compression Quality Metrics During Out-of-Hospital Cardiac Arrest. I want to take a few seconds to thank my co-authors on this abstract, and they are listed below. Disclosures, I'm a current co-investigator for the ongoing Siren Ice Cap trial. A little bit of a background. We know that improved survival in out-of-hospital cardiac arrest is associated with more on-scene providers. This is based out of a study in 2015 out of Resuscitation. We also know that fundamental aspects of high-quality chest compressions include chest compression rate at 100 to 120 per minute and chest compression fraction at greater than 80%. However, what is unknown is the impact of provider number on chest compression quality, including chest compression rate and fraction. Understanding this, we wanted to assess chest compression quality based on the number of pre-hospital providers present at each different time point throughout the resuscitation. So in order to achieve this, we performed a secondary analysis of the Resuscitation Outcomes Consortium Cardiac Epidemiologic Registry versions 1 and 2, which are prospective data sets of out-of-hospital cardiac arrest patients. Dates included were from 2005 to 2011, occurring at multiple sites throughout the United States and also Canada. Inclusion criteria were adults, which were defined as age greater than or equal to 18, who sustained a non-traumatic out-of-hospital cardiac arrest, and who had no mechanical compressions performed. Outcomes included meeting chest compression rate of 100 to 120 per minute and a chest compression fraction of greater than or equal to 80%. Resuscitation groups were stratified based on the number of providers present at each 1 minute interval up to 10 minutes. These groups included less than or equal to 4, 5 to 6, and greater than or equal to 7 providers. Logistic regression analyses were then performed to evaluate the odds ratios for compliance with compression quality metrics by the number of rescuers, with adjustments being made for age, sex, witness status, bystander CPR, public location, and advanced life support versus basic life support first arrival. The total number of resuscitations available in the ROC Registry 1 and 2 were 109,306, brought down to 61,732, which were EMS treated non-traumatic out-of-hospital cardiac arrest. On the right, you'll see our exclusions, ultimately leading us with 18,083 resuscitations, which were included in the final analysis. Taking a closer look at the results here, what we see is that the mean chest compression rate by group size didn't really vary much to meet clinical significance. You'll see here that between the group, the mean chest compression rate only varied between 110 to 114 per minute. However, what we see when we move over to the mean chest compression fraction is that when the group size increased, the mean chest compression fraction also seemed to increase, and that increased throughout the resuscitation. Most importantly, at each time point, greater than or equal to 7 provider groups had significantly greater adjusted odds of compliance with both chest compression rate and chest compression fraction quality targets than groups who had less than or equal to 4 providers. All of these p-values were less than or equal to 0.015. So when we take a closer look, we will see that the 7 or more provider group had a significantly increased adjusted odds for compliance with chest compression rate when compared to the less than 4 group. And this seemed to improve throughout the resuscitation. However, when the 5 to 6 group was compared to the less than or equal to 4 group, there was no statistically significant difference for compliance with chest compression rate. We'll see something very similar when we evaluate chest compression fraction. For the greater than or equal to 7 provider group, we had a significantly increased adjusted odds for compliance with chest compression fraction, which also seemed to improve throughout the resuscitation. And taking a closer look at the 5 to 6 group, we will see that with the exception of minute 1, this group also showed significantly increased adjusted odds for compliance with chest compression fraction when compared to the less than or equal to 4 group. And again, this also seemed to improve throughout the resuscitation. Of course, there's going to be some limitations. It's important to note that the data that we were using was from 2005 to 2011. And there's going to be some guideline differences with this, primarily with regards to chest compression rate. It's also important to note that we did not assess for other compression metrics. These are going to be compression depth, and also for the percentage of resuscitation allowing for full chest recoil. Additionally, it is unknown how mechanical compression devices could have impacted our results. And finally, we cannot adjust for site differences in the study. In conclusion, out-of-hospital cardiac arrest with greater than or equal to 7 pre-hospital providers were more likely to achieve recommended chest compression quality metrics. And we believe that future studies are needed to assess the optimal number of pre-hospital providers needed to attain high-performance CPR metrics in out-of-hospital cardiac arrest. So with that said, I want to thank you for your time and listening to my presentation, and please let me know if you have any questions.